from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about available treatments for epilepsy. Our guest today is First Physicians Group neurosurgeon Dr. Ken Vivas. Thank you so much for joining us.
It's my pleasure to be here.
Briefly, for those who don't know, let's start with the basics of what is epilepsy.
First thing I want to define for you is what is a seizure.
Okay.
Because epilepsy is recurrent seizures. So seizures are an abnormal electrochemical event in the brain that then propagates and causes brain dysfunction. And so some people may have a provoked seizure, for instance, after staying up all night or after drinking too much alcohol and having it go away. But epilepsy is having recurrent, repeatable seizures.
Is there a certain number of seizures a person needs to have, or how often to be qualified as epileptic?
You have to have at least two, and they have to both be unprovoked, and they have to be at least a few hours apart.
Sarasota Memorial has an epilepsy monitoring unit. What happens during an evaluation there, and why is that an important step?
So most of the time when we're first evaluating patients with epilepsy, we're relying on the patient to describe their experience with their seizure. But during parts of the seizure, they may not be fully conscious. And we're then relying on family members for also giving us descriptions. But with the epilepsy monitoring unit, the patient comes in and they're recorded continuously with audiovisual equipment. And at the same time, we're also able to look at their electrical recordings from their brain, their EEG recordings. And that gives us a whole lot more detailed information than we can get from just taking a history from the patient.
How is epilepsy officially diagnosed?
So it's really, having multiple seizures, as I described before, but it's also in these circumstances, it's patients that have medically refractory epilepsy as well. So some patients may come in and have a couple of seizures and get put on a medication, and that's just fine. We can keep their seizures under control. But if you're on over 3 medications and multiple trials, and you're continue to have seizures, or your options are very limited because of side effects from the medications, then that's the type of refractory epilepsy that we're studying in the epilepsy monitoring unit.
That brings me to the next question, because many people do assume that epilepsy is treated exclusively with medication. So when should patients begin thinking about other treatment options?
So just as I was saying, if you're having dose-limiting side effects from your medications, and many of these medications have a lot of side effects. They can cause cognitive slowing, they can cause things like nausea and vomiting, all sorts of different things. So if you're been optimized with your medications, and despite that, you're still having recurrent seizures, then that's the time to think about other options.
So what questions should patients ask their neurologist or meet with a neurosurgeon if they think medications alone are not working for them?
Right. Well, I think it's useful to first start out and say, am I medically refractory? Is the neurologist done with optimization? Sometimes, even if they may be refractory with a general neurologist, that may warrant a referral to a specialty neurologist, an epileptologist, that can give better options for medications and may be aware of different types of medications that could be used. If they're with an epileptologist and they've been with them for some time and they're continuing to have seizures, that's when it'd be a good idea to explore surgical options.
Surgery does sound intimidating to many patients. How has epilepsy surgery changed over the last decade?
So if we look back, maybe 2 decades ago, the mainstays of surgery were removing parts of the brain where the seizures were coming from and disconnecting parts of the brain where the seizures were coming from so that the seizure couldn't move throughout the rest of the brain. And those were very invasive techniques. We're removing part of the brain. Sometimes there's an overlap between functioning brain and the brain that's causing the seizures. And so your hands can be tied in those situations where you can't really offer a resection without causing an unacceptable problem as a result of doing that. Over the course of time, we've taken our experience with things like deep brain stimulation for movement disorders and kind of transferred that over to epilepsy. The first device that was available surgically to treat it was a vagal nerve stimulator. That's minimally invasive compared to these other techniques where wires are just hooked up to the vagus nerve here in the neck, and that provides stimulation to help prevent seizures. And then that then further evolved to having a responsive neurostimulator. So a vagal nerve stimulator, it gives impulses no matter what's going on. It doesn't sense anything. There's no kind of feedback loop that is provided. Responsive neurostimulation, on the other hand, records the brain waves, the electrical activity of the brain, and then only provides stimulation when there is an indication that something is going wrong. And so that's a closed loop stimulation paradigm. And we feel that this is better in cases where we can identify where the focus is coming from because we're able to tailor the stimulation to the brain electrical activity. The most recent one that came along is where we're putting electrodes in the brain, but rather than right where the seizure is coming from, in a more central area, a nucleus in the center of the brain, and we're providing electrical stimulation there. But again, that's open loop stimulation where we're not stimulating in response to some type of activity.
What's the biggest misconception you wish patients and families understood about epilepsy surgery?
Well, I think that most of them consider it very dangerous. And to some degree, that was true, again, about 20 years ago. But with these newer techniques where we're using electrical stimulation to try to stop the seizures, I think it's very much safer. And it's reversible. So we talked before, if we remove a part of the brain, obviously like that, the brain function that might still exist there is gone. But with these newer techniques, if we're causing a side effect with the stimulation or there's something that is unpleasant, we can just change around the programming. And so that gives us this reversibility that I think makes it much less scary and much safer for patients.
You mentioned before a newer implant. So I want to talk a bit more about NeuroPace because people do describe it as a pacemaker for the brain.
Right.
Is that a fair comparison?
Well, I think conceptually from the beginning that was the idea, but we've learned a whole lot about how the stimulation affects the brain, and that's probably an oversimplification. The brain is a very complicated network, and compared to the heart, although the heart is great, it keeps us alive and everything else, the circuitry is just different. So when we provide electrical stimulation in the brain, it's not simply that we want to shut down a certain area of the brain completely. In fact, what we found is that there is a complex modification of the network behavior over time with the use of stimulation. And that's evidenced by the fact that patients that seem to get more stimulation, that we have a lower threshold for providing stimulation, have a better outcome. And so it's not just the stimulation that occurs when there's something abnormal going on. It's the intermittent introduction of the stimulation, even with a lower threshold where there's like only minor abnormal electrical activity, that seems to be helpful to patients.
What is the surgery like itself to place this device? And what does recovery typically involve?
First of all, for the responsive neurostimulation, we need to know at least roughly where the seizures are coming from. Once we get to that part of it, it involves me planning where to deploy the electrodes and then designing a surgery to do that. It's a surgery that's done under general anesthesia. I use a computerized navigation system in the operating room to identify the targets. I then use that system to deploy the electrodes, which usually consists of me drilling small nickel-sized holes in the skull and then using the navigation system to place the electrodes. And then lastly, we have to place the actual device itself. So because the electrical signals from the brain are very small as far as the voltage goes, we need to place the device really close to those electrodes. We can't have it down in the chest because of interference and things like that. So we place it in the skull. We remove a small portion of the skull and we place it with a little tray, and then I place the device there. So all of it is underneath the skin. It's a surgery that takes about 4 hours to do if we're doing both sides of the brain, including placement of that generator. The patient then needs to stay typically 1 to 2 nights after the surgery. So it's not a lengthy hospitalization afterwards. In some cases, we may want to monitor them back in the same epilepsy monitoring unit that helped us make the diagnosis afterwards. In other instances, we may just want to send them home and use the device itself for recording and then programming it.
You mentioned other implants.
Mm-hmm.
How does the NeuroPace procedure differ from those other implants?
Right. So NeuroPace, because I need to have this rough idea of where these seizures are coming from, it's somewhat more complicated because of the fact that we need to do those things and install the device right in the skull. Vagal nerve stimulation is the least invasive. That involves just an incision in the neck and then wrapping the electrodes around the vagus nerve. It's very nonspecific though, and it's not for every patient. The Santee device, which is typically made by Medtronics, and that's implanted in the anterior nucleus of the thalamus, that area deep inside the brain that coordinates brain activity, that is done with a similar type of attitude where we're using navigation to insert the electrodes, but it's a known set of coordinates. It's not something that we're like figuring out ahead of time by watching the patient's seizures. If we think they're good candidates from that, we just go ahead and implant the device in those areas.
So who is typically a good candidate for this new NeuroPace system?
So it's patients that don't have a lot of other medical problems. They have refractory epilepsy, meaning that they've been on several medications, and despite that, they're still having seizures. And that after their EMU recordings, that we have a reasonable idea of where the seizures are coming from. And then especially for patients where the seizures seem to be coming from an area of the brain where it would be unsafe to remove it.
What kind of seizure reduction do patients typically hope to achieve? And is the goal complete seizure freedom, or is it improving quality of life that's equally important?
So, obviously for every single seizure patient I ever interview or talk with, they want seizure freedom, but we can't quite achieve that in everybody. So we will call it a success if we are able to reduce their seizure frequency by 50%. And it's interesting that many of these other devices, they actually can achieve similar results, but they're just different patient sets. So if we can drop the seizure rate to 50% of before, we're happy, but we're obviously always trying to shoot for complete seizure freedom. It's rare that we can ever get a patient completely off medications, but in many patients with implants, we can reduce the amount or frequency of medications as well.
How do you help patients choose the right implant for them? I mean, I know that there's specific things that have to be done for NeuroPace, as you mentioned, but is there anything else that helps you choose between the other two implants, let's say?
Sure. So, part of it is also the risk. We know that the vagal nerve stimulator is relatively simple to place. It doesn't involve any kind of intracranial surgery. So for patients that might be otherwise averse to surgery, that might be a good place to start. For patients that have a lot of other medical problems, that may also be a good place to start with something like a vagal nerve stimulator. Patients that have well-localized epilepsy that might otherwise be a candidate for a surgical intervention where I remove tissue, but that tissue is very eloquent. So the classic example is a patient that has temporal lobe epilepsy in the medial temporal lobe. And on the dominant side, that's where you form your new memories. So we really can't take that out. But if you have seizures coming from that side or both sides, that's another common scenario, then we can't take out that tissue. That's the kind of perfect patient for the use of responsive neurostimulation, because you can place the electrodes right in those areas, provide stimulation, and allow the patient to continue to have good memory function.
So how do you help patients choose what's right for them? Because it is so patient specific.
Right. So what we really do is we are a team. And so I am sitting down with the epilepsy neurologist, the epileptologist, the specialists in that area, and along with other people that are involved in their care, potentially. So pharmacologists, we typically get ancillary information for neuropsychology and other things like that. Radiologists, and we all kind of look at all the data, and we're trying to make sure that all of the data for the patient is pointing us in the same direction, that we're getting consistent results, especially when we're deciding where the seizures are coming from. If everything points to one place, then we would recommend responsive neurostimulation and RNS. If we think it's kind of more generalized type of epilepsy at the onset, we might gravitate more towards the deep brain stimulation or the vagal nerve stimulation.
So it really is very much a team approach to figuring out what's best patient specific.
Absolutely. We want the more heads in that kind of formulation, then it's the better.
So can you talk about the importance of having all of these treatments available to patients in a community hospital setting like Sarasota Memorial?
So I think it's very important because a lot of these patients really, they don't want to travel far away to a center in order to have their evaluation done. And these treatments have become available in community hospitals only recently. But many of us came from academic centers and now are based in community hospitals. I spent 25 years at an academic setting before coming to Sarasota Memorial Hospital. And it's, I still have that same expertise that I had when I was there. And it's the same way with the training for many of the neurologists and other specialists that are involved. I think the unique thing is the ability to expand this to community hospitals where we can then provide these treatments to people locally without having to force them up to specialized centers.
Once someone does have one of these implants, how often do they need to follow up visits and make an adjustment?
Mm-hmm. So in the beginning, it's more frequent because every patient is different, and we're learning what the patient's seizures look like through the device. And then we're designing ways to detect the seizure through the device. And then we're also deciding what's the best pattern to stop the seizure using the device. So patients don't have to come in every single time. These devices allow the patient to actually upload their seizures that have been recorded on their device over the internet for the neurologist to review. And then the neurologist can make adjustments, again, through the internet without the patient necessarily having to come in. So, but we would want to do these kinds of evaluations and design changes more frequently right after the implant. But typically, by the time we're 3 to 6 months out from the implant, it's relatively infrequent. By then, we've established a good detection algorithm and a good treatment algorithm, and then the patients really only need to be seen a couple of times a year.
Can patients travel, exercise, work, live relatively normal lives with these devices?
Absolutely. These devices are really, once they're kind of implanted underneath the skin and the scalp heals, they're able to do any of those types of things like travel, exercise, and do whatever it is that they might want to do with their life. The only one caution really is just avoiding head trauma. So, I wouldn't advise somebody that's had one of these implanted to take up, full contact kickboxing.
Okay, fair. Where do you see epilepsy treatment heading over the next 5, 10, 20 years, now that we've seen changes like this over the past, 2 decades?
Well, specifically for epilepsy surgeries and these types of devices like this, right now we're kind of stuck both with sensing electrical activity and providing electrical stimulation as the kind of solution to stop that electrical activity. But I can imagine that we could very soon be using chemical activity, abnormal buildup of chemicals in the brain that might precede a seizure, and then also potentially using a chemical release device as the treatment protocol afterwards. Or it might be something else that we know stops seizures in the brain. Local cooling is one of those types of things where we might be able to use a special type of cooling device that sits on a certain part of the brain, and in response to the stimulus, we provide cooling to stop the seizure.
So a lot to still explore for these patients. I know we've talked about a lot as far as epilepsy treatment. Is there anything else you want to add before we go, whether it be about the NeuroPace stimulator or anything else?
Well, I think the most important thing for patients to know is that each evaluation starts with education. That when I see a patient, I'm not trying to convince you into doing anything. I want to educate you. I want you to understand what it is that's capable potentially of doing, what are the risks involved, and that it's really a partnership between myself, your epileptologist, and the patient and their family to make good decisions to see if any of these treatments are the right fit for that patient.
Dr. Vivas, thank you so much for joining us today.
My pleasure. Thanks for having me.
If you liked this episode of HealthCasts, please like and comment and visit smh.com/podcast to listen to more experts talking about the health issues which matter to you. And as always, we encourage patients in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.